real pleasure to come and be part of the webinar today. A lot of my career has been in local public health, but I've been involved in academia last few years, and it's brilliant to be presenting on this additional review in Rotherham. Just some of the team listed there. I just want to give a special shout out to Pam at the bottom right there, who led our public participant work. Fantastic involvement from local families and third sector in guiding the evaluation and helping getting involved with recruitment, publicity, all that sort of stuff. So an enormous thanks to Pam and the team for that. So a little bit of background for us. So there was a Public Health England, remember them, evidence review a few years ago, where they identified that there was a gap between the 6 to 8 week visit and the 1 year review, and it was too long for a lot of families potentially, and they said 3 to 4 month visit may be beneficial. And there's some history of that visit existing in England. It was often known as the weaning visit, and some sort of qualitative evidence show that staff remember it quite fondly as it being an important contact point to speak about weaning, but also a host of other things too. But there hasn't been much recent evaluation of adding a visit at this point in the schedule. In came Rotherham, September 2023, they piloted the addition of the universally accessible 3 to 4 month visit, and it's delivered by nursery nurses. It's delivered in the home primarily, and it takes about an hour, so it's a bit longer than some of the other visits as well. And the general rollout to the whole Rotherham population began in January 2024, once they had their full complement of nursery nurses. And some of the key topics they would cover would be breastfeeding, home safety, safe weaning, and parental mental health. But it was also guided by parents as well, what they would want during the visit. A little bit of background on Rotherham, quite an interesting contrast in Camden, about 250,000 people living there, much more settled population in Camden, about 90% white, but a 5% minority of the population identifying as Asian or Asian British. And you can see from the sort of deep purple on that map, you know, quite a few significant areas of deprivation across the local authority area. So ably illustrated by our babies, the aim of the evaluation was to look at reach, effectiveness, acceptability. So who does the visit engage with, demographics, some of the sort of similar stuff that Sarah was looking at in Camden. Effectiveness, ages, what about impact on ages and stages, scores, parent knowledge, onward referrals, and also acceptability. You know, what do parents think of it? What do staff think about it? And what are the barriers and facilitators to having the visit and for staff, and from the staff perspective of implementing it? So we'll start with reach. The way we had a look at this was we took the routine Rotherham NHS data from the trust that delivered it, Rotherham NHS Trust. We went from January 2022 to Feb 2025, excluding pre-2022 because of COVID and the impact that would have on the data. And then used a statistical method called multivariate logistic regression to try and identify which family characteristics were linked with families taking up the service, and also whether maternal mood was recorded or not. We wanted to look specifically at maternal mood, but because of data linkages and things like that, the best we could do was whether mood was recorded or not. So you can see from this chart, the yellow line is the 3 to 4 month visit, and it shoots up to 80% and then stabilizes. And that's about 15 percentage points lower than the mandated visits at 8 weeks and 9 to 12 months, which are about 95%, and that's about 200 babies each month for the team to visit with their families. Really positively, we did see equitability of visit access from deprivation level from postcode data, no clear trend across most of the deprived leased areas. Also, no differences found in ethnicity or maternal age. But we did find that families with more than one child had about a 70% lower odds of receiving a visit. And the qualitative work suggested that might be because they felt more confident in the early stages, but also in terms of being able to organise the visit and that side of things too. So maybe a couple of things going on there. In terms of maternal mood recording, that was equitable again across deprivation quintiles and across ethnic groups. but maternal mood was more likely to be recorded with increasing maternal age. So each 5-year age band, you saw a doubling of the odds of mood being recorded. Essentially, younger mothers less likely to have their mood recorded. And also women who had been pregnant before were less likely to have their mood recorded, 22% lower odds there. On to our effectiveness now. So looking at the ages and stages questionnaire. So this is something that's completed with families. There's a bit of an explanation here. So there's 5 domains. Each are scored between 0 to 60. 6 questions for each domain worth 0, 5 or 10 points. So using sort of the validated scores, this question has been, academically evaluated. Those scores could put a child into the below cutoff place where potentially there's a delay there. They might need referral to assessment. The monitoring section where they get, maybe a little bit of additional support or monitoring or on schedule. So firstly, we looked at if the visit was associated with the proportion of children in that green on schedule bracket. And we found that children offered the additional visit had a 40% higher odds of on-schedule problem-solving development at 9 to 12 months, which is that green line there. The other domains, you could see there's sort of some estimates of small improvements, but because those confidence intervals overlap the line where there's no difference, we're much less confident that that's an actual association. I'll touch a little bit on the limitations of this a little bit later, but problem solving there, you can see a 40% association improvement for those who were offered the visit. And the second one we looked at was the ages and stages. Adjusted mean difference, which basically looks at the total point score on average for the children, and comparing those who are eligible for the visit and those who were born before it was introduced. But again, for both of these measures, we're taking into account the child's age, the mother's age, ethnicity, all those sorts of demographic factors in the model. And here you can see an increase of about half a point for problem solving and personal social. That was statistically significant. There are bigger differences in communication and gross motor again, but because of the confidence intervals overlapping, we could be a bit less confident about those. So it's a small difference, 0.5, but it is a difference that we've spotted. On acceptability, this was answered by our qualitative work. So there were 15 interviews with parents and a couple of focus groups as well, one at a playgroup, one at a mosque. And then we also had focus groups with staff members who were delivering the service and local authority members who were commissioning the service. And essentially we use a framework that tries to get to the hub of what actually is working about this intervention, what doesn't work, what is it about the context that means this is why it's happening. So it's kind of getting to the how and why questions. So parents generally really valued having this extra time to discuss their child's development. They appreciated discussing weaning. Some thought it maybe should come a little bit later, the parents, but the staff were really keen to emphasize that actually a lot of people start weaning a little bit early, and actually the 3 to 4 month point is a really good moment at which to have those conversations before people dive headfirst into early weaning. And some improved confidence described amongst parents. Perhaps unsurprisingly, given what we found with the maternal mood recording, some felt maternal mental health was a little underexplored. Some excellent examples of rapport being built by nursery nurses, described by parents, 1 or 2 parents describing feeling a bit judged and that undermining the rapport that they had. Service signposting came up again and again. People were at a moment at 3 to 4 months where they were starting to think about where they could go out with their baby and support their development in groups and things like that. So they found it a really useful time to find out what was available locally. But there was a little bit of confusion about exactly what the purpose of the visit was. So I think that's a nice quote there that illustrates the fact that the text just had a link and that was it. So perhaps that might explain a little bit the difference between take-up rates. And commissioners were supportive of the visit, but it was externally funded at the time, so that was undermining their confidence a little bit as to whether they could sustain the visit, even if it did evaluate well. A little bit on cost, how many coins in the piggy bank it requires. So there were 3 additional Band 4 nursery nurses who were introduced through a contract variation to deliver the service, and you can see it cost roughly between £120,000 and £140,000 per year. So reflections, most parents valued the visit and they found it reassuring. There was tailored developmental advice, the really important local signposting, but they did feel that the purpose of the visit could be made clearer. It did appear to be culturally tailored, and it had equitable take-up across ethnicity and deprivation levels. Some evidence here of an association with improved problem-solving skills particularly, but the way that the study design means that it's possible that these changes could be explained by other things like changes in national policy or just trend over time. Perhaps babies in Rotherham would have continued improving their problem-solving anyway without the intervention. So we can't rule those things out. And I think it'd be really valuable in future to look at things like infant feeding data, immunisation rates, non-oral referrals, which was data we couldn't collect in this instance. And, we've seen from the chat lots of areas are doing this, so it'd be amazing to do this sort of research. Also look at things across multiple sites too. So our full report is available on the PHIRST website. Click on that link. I'll also put it in the chat. And we're hoping for it to be published very shortly as well too.